My name is Dan Schober. I'm an associate professor here at DePaul in the public health program and also in the chair of the conference planning committee. Had the chance to work with the committee, including Maureen, Suzanne, Christine, Maria, Taylor, Raj, and Gus. I want to thank our planning committee. I also want to thank our conference volunteers. Today's event could not have happened without them. So thank you to them. DePaul's public health program is pleased to be merging with the College of Science and Health and the Department of Health Sciences. We want to thank both the college and the department for supporting today's conference. Now, our theme for today's conference is partnering with communities to build trust and to advance health equity. And we've already begun today's conversation around health equity. We had a great poster session, many good community partner displays, with some critically important health disparities topics, from aging well among Latinx older adults, to preventing SIDS and emergency shelters for migrant families, to intergenerational transfer of health and economic disparities. So I want to thank our presenters for getting our conversation on health equity started. Let's just give them a round of applause. Now, many of you have probably seen this graphic. Used 2009 to 2010 death certificate data from the Illinois Department of Public Health to calculate life expectancy for Chicago community areas. We see that from 2009 to 2010, life expectancy here in Lincoln Park was 81 years. If we go just a few miles to East Garfield Park, we see life expectancy was 72, a 9-year difference in life expectancy. So one question to ask is, have we seen improvements in this disparity over the last decade, or have we not seen improvements? Well, there's some evidence that's recent to suggest that disparities have actually gotten worse. In a 2024 analysis of life expectancy change from 2010 to 2022, we saw life expectancy in Lincoln Park increase by over 2 years. In East Garfield Park, it decreased by nearly 4 years. So this highlights the importance of advancing health equity. We also have some work to do in terms of building trust to actually advance health equity. The 2022 national survey described in a Health Affairs article found that only 42% of respondents felt a great deal of trust in the Centers for Disease Control and Prevention. Only 31% felt a great deal of trust in their state public health departments, and only 34% felt a great deal of trust in their local public health departments. And that brings us to today's conference. We're excited to hear from our keynote panel from the Illinois Association of Free and Charitable Clinics. Then we'll break out into smaller groups to strategize partnering with communities to build trust and advance health equity. We'll come back to this room as a whole group and share these key themes from our breakout groups. And then we'll close with a look towards our next Health Equity and Social Justice Conference. Now, if you haven't seen the conference program, you can bring it up on your phone by scanning the QR code that you see on the screen. And there's the word here right next to the conference title that you can click on, and that will allow you to bring up the conference program. So at this point, I'd like to introduce Dr. Maria Ferreira. She is the co-director of the Center for Community Health Equity. She's also an associate professor in social work, and she will introduce us to our panel.
I do want to take a moment to thank Dan for making this conference happen. There was a lot of details and logistics, and Dan, your attention to details is inspiring and remarkable. So please help me give a hand to Dan Schober. As Dan mentioned, my name is Maria Ferreira. I'm an associate professor in our Department of Social Work here at DePaul. I'm also co-director of the Center for Community Health Equity, which is a partnership between DePaul and Rush. It is an honor and privilege to be introducing our panelists today. Each of them are phenomenal women who have been champions of health equity and certainly know what it means to center the needs of communities. I'll first introduce Melissa McGuire, who's helped put together this panel together and has been an amazing community partner. She's been a social worker for 40 years, over 40 years, and is the executive director of the Illinois Association of Free and Charitable Clinics, IAFCC, working to strengthen the Illinois safety net to maximize the collective impact of free and charitable clinics by representing and resourcing them to ensure equitable, accessible, and quality health care for all. Kamari Thompson is currently the Director of Programs at Mobile Care Chicago. She is a native Chicagoan growing up on the South Side. She has been a fierce advocate for strong communities and for asthma and allergy patients for over a decade, and has worked as a clinical health education specialist. Steph Wilding is the Chief Executive Officer of Community Health, the nation's largest volunteer-based free health center that provides critical health care access to uninsured patients. She is currently the chair of the board of directors for the IAFCC. And Fatima Mirza. She is the executive director of the Be Well Clinic. She has been providing expert consultations in community engagement strategies for health equity and patient-centered outcomes research. Her work has benefited immigrant communities in Chicago, and she is co-founder of the nonprofit organization Worry-Free Community. I'm going to turn over the mic to Melissa, who will facilitate this discussion, but please help me welcome these panelists.
Thank you. I'd also like to thank the Center for Community Health Equity. We've been partners for quite some time, having these important conversations about access to quality health care for all. I appreciate the collaboration with DePaul and with Rush for your continuing to create spaces for us to talk about important issues in order for us to be able to care for those in our community. As I've been introduced, I'm Melissa McGuire. I'm with the Illinois Association of Free and Charitable Clinics, and my colleagues and I, who are sitting there, have a table across the way, Ariana, Shivani, and Naomi. We represent the 50 free and charitable clinics in the state of Illinois, and our role as the state association is to be able to represent and resource them so that they can continue to provide the amazing care for the uninsured and underinsured in Illinois. Free and charitable clinics are a critical part of our healthcare system. They vary in their design, and I won't talk a lot about the different design of free and charitable clinics because our panelists will do a much better job talking about how our clinics really respond to the needs of the community and how we differ in our design based on the needs of the community. Today, while there are 50 free and charitable clinics in Illinois, there's over 1,400 across the United States. What differs for free and charitable clinics than other community health centers is the payee model. Our clinics do not bill for Medicaid. They serve the uninsured, and they provide a very important need for those people that either don't qualify for Medicaid, don't know they qualify for Medicaid, qualify for Medicaid and there's a wait list, qualify for Medicaid and there's no providers. Our clinics provide medical care, dental, behavioral health services, community outreach. And I can't wait for you to hear how they do this in our communities with our panelists. Our free and charitable clinics, one of the pillars of free and charitable clinics are the strong volunteer corps. And again, I hope our panelists talk about the importance of the volunteers in free and charitable clinics. But I think it's important that we talk a bit about the volunteers and the start of free and charitable clinics. 40 years ago, some of our clinics were started by physicians in emergency rooms who said, there are people coming to this emergency room who could be cared for in a more holistic, caring way in the community. And they started free and charitable clinics. Today, we are continually learning about physicians, students, social workers. I think today we talked to a speech pathologist where people are identifying there's a need for those that are not getting the care they need and developing creative strategies to provide health care. In total, last year, our state gave our clinics $4 million to be able to provide care. And you'll see on that poster out there, with that $4 million, our clinics provided $24 million worth of care. And we saved the hospitals from uncompensated emergency department visits $36 million worth of care. I would say a very good return on investment by the state of Illinois. I'd like to wish you all a happy Free and Charitable Clinics Month. We're coming to the end. August is Free and Charitable Clinics Month, and that's the time of our year where we increase the awareness of our clinics, our patients, our communities. We wear blue certain days, we post, the IAFCC team is doing a fantastic job posting, and we partner with these incredible partners. I'd like to thank Governor Pritzker for proclaiming August as Free and Charitable Clinics Month, and I would encourage you all to go to our website at Illinois Free Clinics to learn more. Now, I'd like for us to really learn about free and charitable clinics by these dedicated providers here today that will demonstrate to you what's really happening in providing care for the community and developing trust. So I'll start with Steph Wilding from Community Health to give us an overview of your clinic.
Thank you, Melissa, and thank you so much for having Free and Charitable Clinics here today. As mentioned, I'm Steph Wilding. I am the CEO of Community Health. We are the nation's largest volunteer-based free health center. We're located right here in Chicago with locations in Humboldt Park, Little Village, and Belmont-Cragen. At our health centers, patients who are uninsured can access primary care. They can also access over 25 different specialty care services, especially those that tend to a patient's chronic disease needs, such as endocrinology for diabetes or cardiology for hypertension. We have behavioral health, we have a full pharmacy, and we also have dental care. Now, I've said all of those services that we're able to provide, and I want to also just reiterate, these are all services that we provide completely free of charge. This is typically the time in a conversation when someone asks me, how do you provide all of that for free? And I really appreciated Melissa queuing me up beautifully for that, because our business model is very innovative. We don't bill for our services, and we don't receive any federal funding. So community health, we're able to provide all of these services for free through a three-pillared business model. The first of which is volunteerism. At Community Health, we have around 50 employees, but we have over 1,000 volunteers who make our mission possible. Whether that's a family practice physician, an endocrinologist, a specialist who's a doctor. It could be triage workers, lab workers, and also interpreters, because we provide all of our care in English, Spanish, and Polish, believe it or not. So volunteerism is the backbone of our organization, and it's how we keep costs low in order to ensure that our care is free for our patients. Our second pillar is philanthropy. Like every single nonprofit in the city of Chicago, we are hustling for dollars. From foundations, from corporations, from individuals, we are a nonprofit raising dollars. And our third pillar is partnership. Whether we are partnering with an academic medical center to have their residents placed at our health centers for 3 years at a time, or partnering with large corporations such as major pharmaceutical companies who donate formulary to Community Health so that we can give out those medications for free, or even Quest Diagnostics who donates all of our lab services for free. Between our donated goods and services, Community Health is able to keep costs low so that our services can remain completely free of charge, no sliding scale fee for our patients. And to put some business metrics on that for you, our cash budget is just over $4 million, but when you include all of the donated goods and services, Community Health's budget is just under $28 million. And so that is how we're able to provide $7 worth of care for every $1 that is given to us. And through that care, we're not just providing access, we're providing exceptional access to care. In fact, last year when Community Health was benchmarked against large federally funded community health centers in the city of Chicago, we ranked 4th for quality of care, particularly around chronic disease outcomes, as well as preventive cancer screenings. And we are honored to have been doing this work for 30 years, as Melissa mentioned. This has been a movement that has been going on for decades, and excited to continue talking to you all about that as well. But I think now I'm going to hand it over to my colleague and friend Fatima to tell you a little bit more about her clinic.
Good evening, everybody. Thank you again for having us out here, and thank you, Melissa, for inviting me to this panel. Unlike Stephanie's clinic, our clinic is very new. We are only about 3 years old, exact. So we have a relatively different business model, and we work with wellness models rather than medical care model. So wellness and well-being is part of our free and charitable clinic services. And we started out with access to care programming need in the community back in 2013. And as we were supporting access to care need for the Affordable Care Act, there were a sector of community members that were uninsurable. So that need grew over the period of time, and we needed to open doors for a free and charitable clinic. But we also included all of our wellness services within that, which means all the working with social determinants of health, as well as working with the health inequities with the respect to language and health literacy, and social determinants of health related to income and education and family and health support. So I have actually a sheet here that we put together with all the different models and frameworks that are out there that came after Affordable Care Act. So we started employing these models and using these in our program developments, through which we offer 4 programs. One of them is, I mentioned, access to care, clinical care, and community health trainings, as well as patient-centered outcomes research. So through these 4 models, we are able to deliver a comprehensive set of services to anybody who walks into our doors. We have 2 clinics, one in Oak Lawn and one in Carroll Stream, where we have 2 different clinical models. One of them is a traditional medical care model, and the other one we run with integrative health care model. So that one just came about and will be progressing forward. So we provide care through our partners and through the community medical homes that are already there. So people don't make our clinic as their medical home, but we route them to many different medical homes and only keep those folks who are uninsurable as our patients within our medical home. So this is one of the ways where we're able to keep the costs low while providing well-being services to the entire community. I'm going to pass it on to Kamari now.
Thank you. Hello, everyone. My name is Kamari Thompson, and Mobile Care Chicago was started 24 years ago by a group of physicians that noticed that there was a need for asthma and allergy care in underserved communities. They began to offer those services on a mobile unit, and 24 years later, we are still having that same model of offering our services on mobile units in the most needed areas of the city of Chicago, surrounding suburbs. And we recently expanded into Lake County, Illinois. In that time frame, we have expanded our services to add more wraparound services like dental care, as well as we've layered on different services related to asthma and allergy care, like indoor and outdoor air quality monitoring and home assessments. Our services are pediatric, and we have our model of care is that we go into the communities to eliminate the barrier of people being able to get to a location. We will see people regardless of their status legally or whether or not they have the ability to pay. We do not charge for any of the services that we render. We cover the cost of all of their treatments as well as any medication that they may need. And we're able to do this because we fundraise throughout the year. We work with wonderful people like Melissa who can help us secure funding from the state of Illinois, and we also write for grants so that we're able to continue to provide that care. And we really just want to make sure that we are able to continue to provide that service without boundaries throughout the city of Chicago, surrounding suburbs, and even expanding into different collar counties of Cook County.
So a lot of you have talked about how you address some of the health inequities of the patients in the communities, and if you would like to just take a moment and kind of circle back to that and focus it that because part of what we're talking about today is addressing the health inequities and building trust. So if you could speak to some of the ways in which, strategies in which you have your program, your clinic, your organization has addressed some of what are the health inequities of your community and how you address those. I went the wrong order there.
You're all good.
See, clinics are very nimble and responsive. I made a mistake in the beginning and they've adapted so well.
So, before getting into some of the strategies that community health uses, maybe setting some groundwork about the inequities that we see in our clinics. So for our patients who are uninsured, who are typically ineligible for federal Medicaid due to their immigration status, the number one inequity that they experience is just general lack of access to care. That could be because they live in communities where there are not affordable options. It could be because they don't have transportation or can't afford transportation to other communities where there may be affordable options, or even the financial burden of taking that transportation but having to take time off of work and therefore missing out on income that week. So just generally speaking, there's a lack of infrastructure access to care for the communities that we serve. As a result of that lack of access to care, those communities experience health inequities related to their health outcomes. So at community health, for example, our patients, 55% of our patients have at least one chronic condition, such as diabetes or hypertension. In the last few years, community health has scaled up and opened new sites. And at one of our locations in Little Village, the first 6 months that we were open, 35% of the new patients that we saw had diabetes, and all of them had A1Cs of 12 or higher, which if you're not a clinician, I am not, but I know just enough to be dangerous on this, and that's very high. That person's condition is not under control. So to give you that perspective of those patients, they have been out of care for months and sometimes for years. And as a result, it has impacted their overall health and wellness. And then when we add in factors like, what is this person's access to healthy foods in part of their wellness and treatment plans? Do they have grocery stores in their neighborhoods? Is there a safe place for them to exercise? Those other social drivers of health that are still related to physical health, not to mention intergenerational trauma, gun violence, and other things that may impact their day-to-day wellness. And so community health, we really pride ourselves on ensuring that we have a comprehensive model that meets patients where they are, both physically and as an individual. So as I mentioned, we have a breadth of services that help to attend to all of the health conditions that our patients may experience. And something like specialty care for a diabetic patient who is uninsured is almost impossible to do anywhere but really Cook County. And so the fact that community health can offer this service is one of the strategies that we try to deploy to ensure that there's high quality care being provided. But we also meet our patients where they're at, in that we're speaking to them in the language that they want to speak in and that they want their care to be in. And so having all of our resources being Spanish and Polish, as well as on-site certified interpretation, is very critical in ensuring we're meeting our patients where they're at. The other piece is, as I mentioned, community health has been opening up new locations in recent years. If we can all just take a quick time journey with me and go back to March of 2020, which I know none of us want to do that, but overnight, every healthcare institution, community health included, pivoted our models to be telehealth based. And at the time, what we saw at community health very quickly was that more of our patients were able to attend their appointments. And it was like, oh my gosh, no-show rate has plummeted. This is amazing. What's happening here? And the answer was so obvious. We were calling our patients on their telephone. We were meeting them where they were at, rather than having them, I mean, Community Health, our headquarters location is in Humboldt Park, but we serve patients from every single zip code in the city of Chicago, as well as parts of Indiana and Lake County. Folks are traveling far distances to come see us. But now we're just like, hey, what's up? Let's call you. Let's talk about your medical condition. And so our patients were getting more and better care because we were meeting them where they were at. So Community Health has doubled down on our commitment to health equity by continuously challenging ourselves to rethink space and place for point of care so that we're meeting our patients where they're at rather than requiring them to come to us. So what that has looked like is we have begun to open up micro health centers inside of existing community-based organizations that are serving our patients social drivers of health, such as food access, child care, immigration assistance. And at these facilities, it is literally like a micro, it's a cute little clinic, a couple of exam rooms, but we're able to put a door in the community where a door previously did not exist. And we, rather than giving our patients a bus pass from Little Village to come to Humboldt Park, we packed our stuff up and opened a door in Little Village to be there for the community. And so, to me, that is one of the opportunities, particularly in Chicago, where you saw that graph of the disparity between life expectancy. There's a lack of investment in those communities in a myriad of ways, but in actual healthcare access. And in healthcare, we focus on talking, oh gosh, I'm getting in my soapbox, I can feel it. But in healthcare, we talk a lot about how do we get transportation right? How do we get transportation right? But in community health, we're saying, what if we put a door there instead? What if we invest in the communities, have those investments be informed by the communities? Our microsites have been completely driven by our patients and by the community so that we can continue to make them better and for the community. And as part of addressing not only health inequities, but also structural racism, investing in those communities. Sorry, that was the longer answer. I got excited about that.
It was great. Thank you so much. Thank you so much.
So I'll try to be fast and short. So we use a community health ranking model to organize all of our programs and services. And according to the community health ranking model, clinical care and access to care is about 20% of the total healthcare outcomes, or it constitutes about less than 20% for the total health outcomes, which is quantity of life and quality of life. So we actually, what we have decided to do is train volunteers in community health work and plug them into it as outreach or community health volunteers across the mosque communities throughout the greater Chicagoland area. And after Friday prayers, people can interact with them and they become conduits to collecting information and having to provide that door, in Stephanie's terms, for those people who don't have access to care or who have additional issues with their health problems, even with access to care. So that's one of the several ways, but that's one of the most effective ways we do it.
So at Mobile Care, I think that when we talk about health inequities and the barriers, that those things will sound very repetitive. So access to care and socioeconomic status and the financial strains that can be placed on the family. And all of those things we see in our patients or in the families that we serve. What we've done is literally in the model of how we do things, we're mobile. We go to them. We make sure that the first thing we do is eliminate the barrier in them being able to get to us. We take it even a step further because kids go to schools, and so do we. We pull up our mobile units outside of schools, and we see kids not only enrolled in that school, but who live in that community. Prior to the pandemic, we started a model of virtual visits because we noticed that we would be at the schools, the kids would be at the schools, but the parents couldn't show up. Parents had work obligations, they had other family obligations, they had other personal obligations. So we decided that if the parent could just talk to us on the phone, if they could just FaceTime us or whatever medical platform that they were able to download. And this was prior to the pandemic, so there wasn't a lot of talk about the doximities and the different medical platforms. But if they could just get on the phone with us, we would be able to get the child out of school, go through the visit with the parent being there. It gave a level of safety and security to the child, and it gave the parent the ability to be able to care for their child while still taking care of other priorities and obligations. And when the pandemic hit, we went full on virtual. So we had some experience there. So that's one of the other things that we did to reduce the barriers to care. Another thing is that we know that in the communities that we serve, sometimes health, being as important as it is, can be one of the lowest priorities. So what we have decided that we could do is to try and make that access as easy as possible so that parents didn't have to make such a huge fuss about how they receive care. We meet them where they are, however we can. In some cases, this means talking to, just doing a check-in with the parent and the child is not there. And sometimes this means making sure that the parent knows that they have access to us 24 hours a day, 7 days a week, 365 days a year. This is making sure that if they can't get to a pharmacy, we'll drop off medication. So these are all of the things that, or some of the things that we're able to do. We decided that we wanted to layer on services, and because one of the things that we found is that we are able to manage a child's asthma in a certain space, but we also have to send them home where there may be tons of triggers. So we started to do home assessments. And if we can't move a person into a better environment, at least we can make that environment more safe. So we decided to start doing allergy skin testing and allergen mattress and pillow covers and air purifiers and all those things that can make us the home a safer environment. Then we also started to communicate with the school to make sure that the school was creating a safe environment so that the kids were not triggered inside the school building. So we just took a very broad look at all of the things that our families were encountering and tried to figure out how is it that we can step up to make that an easier, make access to care easier for them. And one thing it did is that when you make things easier for someone else, it may make things harder for yourself, but we were 100% willing to take on that challenge.
Are we following the same time frame?
Yeah, you have about 5 minutes, and then we want to make sure there's some time for question and answer.
Wonderful. I could hear them talk for hours, couldn't you? Just amazing. So one of the last questions that we would like Fatima to share with, and if anybody else has, when we talk about the importance of care, we talk about data, we talk about community, we talk about outreach and research, right? Here we are at a university research, and there's been some very phenomenal posters that are up there, and you've all engaged in research at different levels. So one of the areas of research that we would like to chat and talk about here is community-based research. And we have one of the experts on our panel, so we thought Fatima could speak a bit about community-based research and what you all have done with that.
Thank you, Melissa. That's my favorite subject, really. Okay, so we started out as I didn't have a vision for nonprofit, by the way, and neither did any of my other co-founding members. We simply responded to a community need. 2010, Obamacare passed, or Affordable Care Act passed. In 2013, October, Marketplace opened up, and there were calls that were flooding because we actually partnered with among several mosques, and we were doing health screenings for several mosques. So we were collecting data at a community level even prior to 2010, but it was completely voluntary, and I was simply interested because of my professional expertise. Anyways, fast forward, I started looking into that, and with the Affordable Care Act, there were many, it actually is a bundle of tools. And one of the tools that we have in that law, or in that box, is patient-centered outcomes research. That institute was established with the passage of Affordable Care Act, and it has many different engagement tools and scientific tools for methodological scientific tools. So the way it differs in community research is I was doing community-based participatory research prior to Affordable Care Act, but with Affordable Care Act, now we can do patient-centered outcomes research. Now, that is approach CBPR versus PCORI, that is methodology. So the methodology has about 65 standards, and it is a beautiful toolkit to utilize at every single step of the way when we are doing community-based research. And engagement, and there are actually also engagement tools in that methodology where it offers about 6 different engagement principles, which we at Worry-Free Community, it took us about 5 years to organize those principles into a process. And we now have a process to engage and build trust with any partners or collaborator that we work with. And we are definitely putting it to test. And these are some hard tests that we're going through. So trust that you think got established, but then it got revoked. But then how do you rebuild that trust that gets revoked? And this is the point where Picori's engagement principles really are doing a wonderful job. It is guiding each step of the way how to reinstate trust that's broken, as well as to establish trust as. So we have some insights that we can share, and of course I would recommend everybody to look into that, into those methods. And I actually have a sheet out here where I've listed all of the different tools frameworks that we employ in our course or in our work on a daily basis.
So as you can see, free and charitable clinics are responding to the community, strength-based services, identifying resources, and really providing quality care. So we thought we would open it up for some questions, if you have any questions. In the back of the room? Should I bring this back there?
If you could speak loudly.
Okay. So my interest is trying to connect healthcare with social justice from the perspective of you have a client who's living in a facility, housing facility, who's receiving medical services, who is going to school, whatever. And in their particular situation, they are experiencing structural violence and racism, and they need someone to assist them in dealing with that because it's affecting their health. I haven't heard too much in general about how does that person receive help and care that connects health care with social justice.
So that, again, health equity is a combo pack between healthcare and social justice. And that's what you're talking about is patient-centered care. So in our work, we actually deploy the County Health Ranking Model, and according to that model, about 40% of the problems in healthcare arise from social and family support. So that's a perfect example right out there, and we have processes that we have established with our community health worker, community health volunteers, and community health workers who can use the co-learning techniques to understand the methodology, who use those techniques to understand that patient's situation and then assist them through the resources that exist within their own domain of, or where they live and work.
Yeah, if I could add to that a little bit, as a health center that's doing direct services, I mean, I think one of the main services that is needed in just helping someone deal with what you just described is around mental health access. And we know that mental health care continues to be a struggle for people to access, and even at community health, where this is a service we have, that we've expanded, we continue to have and maintain a wait list. I think kind of taking it up to the theoretical level though, you know, being a community health center, I often talk about the ways in which, as a community health center, our exam rooms, when a patient arrives to our exam rooms, they are bringing with them the totality of all of the broken systems in society, which includes structural racism, which includes violence, which includes education and inequities. And when a patient arrives at our exam room, we are being looked to address the totality of that experience. But it's often, and this isn't the prettiest picture, but it's often the mandate is how can we get someone emergency food access right now? How can we get someone an emergency appointment with a psych NP? I describe the exam room and what we do as like the town square where all of the roads to the broken systems lead. And so I kind of counter, this is not probably what you're looking for, but I sort of counter that question with something that I've been exploring myself as a leader of a community health center is, where are we moving upstream amongst these broken systems to say, well, uninsured folks or folks in general can't afford medications because they're not earning a living wage, not a minimum wage, but a living wage. And so in what ways are we interacting with these other roads that lead to our exam rooms to try to address the upstream impacts that land in our exam room? Which I'm not sure answers your question, but it's something that I think touches on it a little bit.
One last thing.
Yeah.
Do you work or partner with lawyers or legal representation where it's needed?
So I will just answer really quickly for community health. The answer is yes to that. The vast majority of patients that community health is seeing though, the legal assistance that they need is related to immigration or is related to violence that they've experienced that now make them eligible for a certain documentation status that they wouldn't have had access to if a crime had not been committed against them. So that's the way we interact with lawyers most often. I will say before the pandemic, community health had been aiming to work more proactively with people who had been previously incarcerated, ensuring that while they were waiting their Medicaid, they were able to get access to care at community health, get all of their services right away as they awaited that medical card that would give them additional options beyond just a free health center serving uninsured folks.
That was the same question. I was going to ask about that prevention as well in upstream. And so, number one, what type of, like, far as community support and what type of, like, we have people here that go to school for actually this, you know, people are always interested in this. What can we do to support the kind of work that you guys are doing?
Before I go individually, you could go to the Illinois Association of Free Charitable Clinics website.
Okay.
We are the state association for the state of Illinois clinics, to include the 22 in the Chicagoland area. Mm-hmm. And if you're interested in specific clinics, that just specific clinic work, we have a list of all the clinics there, mm-hmm. and you could find a clinic and outreach to that. We also have an advocacy and policy committee person right there. That we are always looking for ways in which we can go upstream through the state association with advocacy and policy. And then I'll hand it over to the clinic.
Then I want to add just one thing. Because the reason why I say that is because, you know, a lot of times this type of information doesn't get back to the community, number one. And then also too, you know, a lot of times the work that you guys are doing can be supported in ways that maybe not have been discovered. And so it's always interesting to see how, everybody interacts instead of working in a silo. And that's the reason why I asked the question.
That's wonderful.
I could add a little bit about that.
Yes.
Yeah. I think one of the greatest lessons that safety net healthcare providers learned during the pandemic was that power of breaking down those silos and trying to lock arms with organizations we maybe hadn't worked with before. And so there are a few projects that are going on in the city of Chicago that are focused on healthcare transformation but are breaking down those silos you mentioned. So HFS made investments in healthcare transformation projects. I think there's 4 or 5 in the city of Chicago where entities are all coming to the table. You could be a healthcare provider, you could be a community-based organization, you could be other community-based groups that are coming together doing that work. Also during the pandemic, the city of Chicago identified health equity zones throughout the city of Chicago where there are leaders in each of those, I want to say it's 8, but please don't quote me on that, 8 equity zones. Again, it's not like the last meeting we went to, we were one of the only healthcare providers, and instead we got to interface with all sorts of different organizations that didn't know about us and we didn't know about them, and we ended up developing new referral partnerships and things like that. So there are initiatives taking place, and this is city-based, in the city of Chicago that are really bringing key players to the table, but honestly, it still continues to be a challenge. It still continues to be a challenge, and there's a lot of efficiency that's lost in that siloing of the different sectors that are working on the same type of justice efforts.
I just wanted to say one other thing. I think that I think we've lost or we let go of the power of word of mouth. So there are hundreds and maybe thousands of people that could use the services that 3 of our clinics provide. So I would say if, one of the easiest ways to help us, to help the communities that we serve is to let people know about the services that we provide. And let people know that they can reach out to us. I know at Mobile Care Chicago, and I'm pretty sure it's true for the other 2 clinics here, is that we are welcoming new patients and we won't turn anyone away. Like, we want to be able to expand, and having too many patients is a good problem to have because it challenges us to be able to figure out how do we expand our services to be able to cover as much ground and provide as much support as we can. So I don't want it to get lost on how much individual spreading of this information could go.
Thank you. Again, I would just like to thank you for this opportunity to share. The conversation continues. We have our table is out there. We would welcome conversation in our small groups, and thank you so much for this opportunity.
Thank you for those really great questions, and you may have more questions. The afternoon is not over. We're going to be breaking out in sessions. We're about 10 minutes behind, right? So but let's please give another hand to the